are you?
Good, thanks. How are you?
Good, thank you.
Do you want to practice sharing your slides? Are you comfortable?
Sure, I can share so long. Are you able to see everything?
Not yet, but maybe that's because I'm sharing something. Yes, now I can see your screen. And it's advancing. Perfect.
Good. Okay, perfect.
Thanks, Garrick. Cheers.
Okay, no problem.
Hi, Heather. Hi, Jared. How are you? There we go.
Cool.
That's
How are you
doing? Mute me. Good,
Hi,
thanks.
good morning.
Hello.
Hi there.
All right, cool. So I just want to check then. Must I just share the slides that
Yes,
with-
if you're comfortable and you've got it there, then that would be great.
right. Just find my way. Cool.
Perfect. Looks good.
Okay, so then should I just go through the slides at the start and then introduce the speakers? Amazing. And then I just want to check, are we going to do questions at the end for both speakers?
That's fine.
Heather, you found with that? I saw Garrick was on. I don't know where he's
Yeah.
gone now.
Yeah, no problem. Happy
Everyone, I'm still
with
here.
whatever.
Okay, cool. Sorry, you had disappeared on my screen. Cool. So then I'll introduce you both. I'll go through the housekeeping slides and then introduce you both. And then do you want to just, sorry, I'm trying to find the emails now, they've all disappeared. So then I'll introduce you both and then Heather, you start, and then Garrick, do you just want to follow straight on? And then we'll do the Q&A afterwards.
Thank you.
And
Cool.
then, Heather, the poll, I've made it for you. Can I show you how to bring it up?
Oh, yes, please do.
Sure. So at the toolbar at the bottom of your screen, the far right, just before it says leave meeting, there's the more with the 3 buttons.
Mm-hmm.
And then if you click on that, the very first option, polls or quizzes.
Yeah.
And then option 1, it's got today's date, says deep dive, hematology and pregnancy. If you hover over it, it'll have an option to say launch. And then we can do it now. I'll show you how. And it brings up the
There it
questions.
is.
And as long as you can see it, everyone else can see it.
Okay, perfect.
And then, yeah.
I think with the polls, because I've done this before and it made me panic, I think we'll be able to see the answers loading.
Yes,
I think they'll only show the answers will only show once you say end poll.
correct.
Okay.
And it only shows the person that started the poll, if I'm not mistaken. Because I'm not sure if these 2 questions are from the same slide or if they're the
They're
ones
not, they're separated.
Okay, so maybe you'll just need to launch the poll again for the second question.
Okay, no problem.
Cool.
Cool. Yeah, so then when you say end, then you can say share results there.
Can you also see that at the same time, I'm assuming? So then everyone
Yeah.
can see. Okay.
Yeah, so I think all the panelists
host.
and the
Okay.
hosts, yeah, can see because I know we did it once, we actually used it to vote for something. And we had a panic because we could see them coming through voting for people for our executive committee, and it was a bit of a panic that everyone could see it, but it was only once you share the answers that people can see the actual answers.
Makes sense.
Yeah.
This will be lower stakes.
Okay, awesome. Heather, do you want to test your slides?
Let me stop
Yes,
mine.
sounds great. Let me- let me just flip.
Perfect. Looks good.
Okay, fantastic.
Awesome. So I'm going to play an intro video in the meantime, and then at 4 o'clock, I'll turn it off, and Jared, it's over to you.
Yeah, do you want to just check that Garrick can share his slides?
We did check it just a few
Oh,
minutes
you.
ago. Yeah.
Ah, amazing. Keep you on the ball, Garrick.
Yeah. Well, sort of.
Okay, cool. So then we'll start at 4. See you guys now.
Yes, perfect.
Thank you.
Good afternoon, everybody, and welcome to today's deep dive presentation. Oh, sorry about this. I'm just trying to sort out my slides. Welcome to today's deep dive presentation. My name is Jared Zamperini. I'm a physician based in Joburg with an interest in medical problems in pregnancy. So I've been asked to chair today's session, which I'm very grateful for. Thank you to the Blood SA team for inviting me. And I'll introduce our speakers now. So we'll be talking about hematology and pregnancy. But before we kick off, I just want to do a little bit of housekeeping. So firstly, today's deep dive is brought to you by Blood SA and WITS with our strategic partners, who we're very grateful to. The deep dive management team, who you can see there on your screen, we are also very grateful to them because they bring us all of these wonderful presentations, which I'm sure many of you attend quite frequently. So thank you to the deep dive management team. Just some housekeeping. All these sessions are recorded. They can be found on the Blood SA website, bloodsa.org.za, under Resources Deep Dive. Please feel free to add any questions or comments to the chat box during the meeting, and we'll respond to them at the end of the presentation. CPD points, which is obviously everyone's big concern with all the HPCSA things going on. They will be submitted directly to the HPCSA, but please ensure that you are attending with your own Zoom link, not in a group. You must be online for at least 1 hour, and your HPCSA number must be entered correctly when you sign up for Deep Dive. If you do have any questions or concerns, just email admin@bloodsa.org.za. The mailing list, you can join the mailing list via the website, or you can use that QR code. And please, if you have any feedback, complete the anonymous survey at the end. We do value the feedback, and the speakers value the feedback. The last thing before we get into today's talk, HHT Horizons is coming up in September. The conference registration link is in the chat. It's been posted a few times. Attendance is free of charge, so please do have a look at that and register for HHT Horizons. So that's all the housekeeping, which brings me great pleasure to show you our agenda for today. So we're going to start off speaking about RH immunization, RH disease in pregnancy by Dr. Heather van der Meulen, followed by thrombocytopenia in pregnancy. We're going to go straight into the second talk, and then we'll do Q&A for both talks at the end. So our first speaker is Dr. Heather van der Meulen. She is a hematologist and transfusion medicine specialist at Sunnybrook Health Sciences Centre in Toronto, Canada. And she is also an assistant professor at the University of Toronto in Canada. So Heather is joining us it's about 10 in the morning there. So we're really grateful that she can join us. Her clinical and academic focuses are on obstetric hematology and alloimmunization in pregnancy. Our second speaker, a little bit closer to home, Garrick Lawden, is a clinical hematologist at WITS and at Chris Hani Baragwanath Academic Hospital here in Joburg. He qualified as a specialist physician after completing his reg training and his MMed in internal medicine at the University of Pretoria in 2019. He then crossed the Yukske and did his specialist hematology training here at WITS, where he has not been let go. So we still have him on board, and we're grateful to have Garrick and Heather both speaking to us today. Finally, just next week to let you know, the talk will be on MRD matters, measurable residual disease in B lymphoblastic leukemia by Dr. Theo Gardner. But now I'm going to ask Heather to share her slides, and we are going to start off with her talk. So thanks everyone for joining us, and thank you, Heather, and Garrick, both of you, for joining us.
Wonderful. Thank you so much to the organizers for the invitation to speak today. So my name's Heather van der Meulen. I'm a hematologist and transfusion medicine specialist in Toronto. So good morning from Canada. And I'm going to speak today about alloimmunization in pregnancy and really focusing in on RHD. I have no disclosures that are relevant. By the end of today's talk, I hope the audience will appreciate the clinical spectrum of hemolytic disease of the fetus and of the newborn, to be able to apply an approach to managing an alloimmunized pregnancy, and really just to have a high level awareness, recognizing that we're not maternal fetal medicine specialists, but an awareness of what intrauterine transfusion therapy looks like. So let's start with a case. So this is a 31-year-old female. She's G2, currently 13 weeks gestation, and she's referred to you for a newly detected anti-D on her first trimester antibody screen. So her obstetrical history is significant for a first pregnancy in 2021. Her antibody screen was negative throughout. She did get prophylactic Rh immune globulin at 28 weeks gestation, but she had a spontaneous vaginal delivery at home and did not get her rig dose administered at delivery. Her current pregnancy is with the same partner and uncomplicated to date. She's otherwise healthy, taking some prenatal vitamins, and has no history of, most relevantly, injection drug use. So when we look at her investigations, she has a normal CBC for pregnancy. Her blood group is O-RHD negative, and her screen is positive. An anti-D antibody is identified at a titer of 1 and 2. So let's take a step back for a second and understand what exactly alloimmunization is. So remember, this happens when you're exposed to non-self red cell antigens, and this can happen through various routes of exposure. But when you are exposed, you can mount an immune response that initially is primarily IgM, and in most cases will evolve to become an IgG antibody. In about a third of cases, and some antibodies are more common for this than others, but you will have what we call evanescence, where the antibody will transiently disappear. So for example, between pregnancies, the screen may become negative. Upon re-exposure, the IgG antibody can then, in the case of pregnancy, bind fetal red blood cells. In the case of, for example, if this were a transfusion, it can bind transfused red cells. The IgG antibody binds those red cells and hemolysis results. And when we look at the most commonly known causes for alloimmunization, so this can happen through a prior transfusion episode. Paternal antigen exposure, so via pregnancies. But remember, solid organ transplant, and increasingly recognized is that there's likely a role of intravenous drug use, for example, with needle sharing as a cause for alloimmunization. And for something like RHD, which we label as a potent immunogen, so something that can readily trigger your immune system, it only takes 0.1 mils, which is the equivalent of really 2 drops of blood to trigger alloimmunization. So in the case of pregnancy, often in a first pregnancy, if this is the source of alloimmunization, here we have an RHD positive fetus and an RHD negative mother. There's fetal maternal hemorrhage, so there will be fetal blood that crosses the placenta, and this happens increasingly throughout pregnancy and then at the time of delivery. This is enough to alloimmunize a mom. Rh antibodies are then formed. Initially, they're going to be IgM. So remember, your first pregnancy is rarely affected, but then upon subsequent pregnancies, you have IgG antibody. And this IgG antibody can cross the placenta and target fetal red cells if they are positive for the cognate antigen. So we spend a lot of time talking about RHD, and rightfully so, because this is one that we do have therapy for to prevent. So remember, we're giving our prophylactic Rh immune globulin throughout pregnancy in RHD negative mothers. But there are 47 blood group systems identified to date, and encompassing a total of 366 antigens. So while RHD is a major focus and still remains the leading cause of severe disease, there are many other antibodies that can cause disease for which we do not have a preventative treatment for at this time. In affected pregnancy, there are a range of potential clinical outcomes. So despite having a fetus that is antigen positive and a maternal antibody, there can be no disease. Mild disease refers to isolated hemolytic disease of the newborn. And severe disease refers to an affected fetus. So this is where there's fetal anemia requiring intrauterine transfusion. All of this, the most dreaded outcome is fetal hydrops. And so when severe disease is unrecognized, this can progress to fetal hydrops, which ultimately is a fatal condition. In any given pregnancy, the severity of disease is going to be impacted by the identity of the antigen. So for example, is this an anti-D or is this an kid antibody, for example? The fetal expression of the antigen. So remember that throughout
what is that thing?
Oops, sorry. So throughout pregnancy and throughout gestation, the fetal expression of various antigens is going to vary. So for example, we know that K antigen is expressed very early, whereas something like ABO is not going to be expressed very well, even at the time of delivery. And then lastly, the nature of the antibody. So is this an IgG, which is a smaller antibody that is actively transported across the placenta? That can cause disease, whereas an IgM antibody, it's, remember, a pentameric structure, does not readily cross the placenta. And not all antibodies are created equally. So this is just a nice table that was created by some colleagues in Canada, where they go through both common or antibodies that are commonly associated with hemolytic disease of the fetus and newborn versus not, and their associated severity. So here you'll see that our most severe and common causes of severe disease of hemolytic disease of the fetus are your Rh and your K antibodies. And when we look at large cohorts, we see that those that require intrauterine transfusion are disproportionately anti-D or anti-K. So these are really the bad boys in the world of hemolytic disease of the fetus. Okay, now let me just try and launch a poll. I'm going to get everyone's input here. Oh, it's changed from the time I practiced this a few minutes ago. Is it launched?
Not yet.
I've launched it for you there, Heather.
Thank you. So which of the following is or are the most appropriate next steps? So phenotyping the paternal red cells for the D antigen, referring to maternal fetal medicine for MCA Dopplers, screening for maternal hemolysis, sending cell-free fetal DNA to predict RHD, and repeating antibody titers or administering prophylactic RIG. Are people able to answer? Yes, okay, wonderful. Okay, I'll give everyone a few more seconds.
We have quite a few answers rolling in. There are 26 out of 150 though, so I'm sure the other 80% on the chat can get back. We can't see exactly what you answer, so it won't be held against you down the line.
Okay, I think things have slowed down. So last few seconds, and then I'll share the results. Okay, so most people are checking Oops. Most people are either referring to maternal fetal medicine, monitoring antibody titers, giving prophylactic rig, checking paternal antibody status. Okay, or antigen status. Okay, wonderful. So, I'm going to propose that these are all reasonable options. So always checking DAD if paternity is known for the RHD status. Again, we'll talk about the limitations of this shortly, where we actually can't determine clearly zygosity, so whether DAD is homozygous or heterozygous for D. At this point, I would argue we don't need to refer to maternal fetal medicine. Remember, mom is D negative. You always develop an alloantibody to something you don't express, so we have no reason to think that mom would be hemolyzing. I agree, cell-free fetal DNA for RHD status is reasonable and appropriate, and we will monitor titers. Remember, the whole reason we give Rh immune globulin is to prevent the formation of an allo-anti-D. And the horse is out of the barn. Mom has already made an anti-D, so there's no point in giving her prophylactic rig anymore. So management of these cases really, so first we just talked about identifying risk. And so it depends on the nature of the antigen, whether it's IgG or IgM. Paternal phenotype can be very helpful, especially in cases where we don't have cell-free fetal DNA. But we do have cell-free fetal DNA available for D, Rh big C, little c, big E, and the K antigen. When we think there's potential fetal risk, the next step is to monitor with titration. And remember, this is where we're checking the strength of the antibody by progressively diluting the sample and seeing how many times can we dilute it and still detect the antibody. In the first and second trimester, we do this every 4 weeks, and then in the third trimester, we do it every 2 weeks. And all with the goal of identifying a critical titer. And above that titer, we do more invasive, or sorry, we do further non-invasive monitoring with MCA Doppler ultrasounds. Now, remember, everything we're doing in pregnancy is for the sole purpose of identifying hemolytic disease of the fetus. If there's a jaundiced newborn or a mildly anemic newborn, we don't need to know about that in pregnancy. We can deal with that at the time of delivery. Everything we're doing here is to identify an anemic fetus that requires intervention. So in cases when we reach the critical titer, and we'll talk about that in a second, then we refer to maternal fetal medicine or a high-risk obstetrical provider for monitoring of the middle cerebral artery by a Doppler ultrasound, and this is a marker of fetal anemia. In rare cases where we do identify fetal anemia, we do fetal blood sampling. So we directly monitor or sample the fetal blood count, and if babe is anemic, then we do intrauterine transfusion. So going back to our case, so I alluded to the fact that dad's blood group might not be super helpful in all cases, but the best we can do is to look, so we find that dad is A positive, so he does have RHD on his red cells, but we have no way to determine if he has 1 copy of D or 2 copies of D. So homozygous or heterozygous, because remember, there's no antithetical antigen to D, it's you have it or you don't. But if you remember, your DCE antigens on each allele are inherited as a package. And so what we do is a little bit of guesswork. By phenotyping for the C and E antigens, we're then able to look at the frequencies of the haplotype and say, what is the most likely combination that he would have? And so in his case, based off what he's expressing, we then map to the frequencies and we see most likely he has 1 allele that has the D antigen on it and another allele that does not. So we suppose he's likely heterozygous, but again, this is all, it's not foolproof. In cases where dad is heterozygous, and again, kind of depending on your philosophy, so acknowledging first the potential for non-paternity, so remembering that there are going to be a certain percentage of pregnancies where dad is not who we think dad is, and then further, how confident we are in our ability to infer zygosity. Many cases, we will send for cell-free fetal DNA to predict if the fetus is RHD positive. So in our case, we continue to monitor her titers. So sorry, I forgot to mention, let's say the cell-free fetal DNA comes back and is positive in her case. So we continue to monitor titers every 4 weeks. And then you'll notice that at 18 weeks, she's jumped 2 dilutions, so 2 tube dilutions. And for us, that's a signal that the antibody might be getting stronger. We need to watch more carefully. So we increase our frequency to every 2 weeks for titers. And then at 20 weeks, she's now at 1 in 32. So what now? Okay, can I kindly ask for help launching a poll again? This is the second and last poll. So what is the next most appropriate step in her management? Is it to arrange for Doppler ultrasounds of the mean cerebral artery? Is it to arrange for fetal blood sampling and intrauterine transfusion? If needed, is it to repeat the titer in 2 weeks or to administer IVIG 1 gram per kilogram weekly? Okay, I'll give it a few more seconds. Okay. So the most popular response is to arrange for a Doppler ultrasound of the fetal MCA, which I agree. Okay. So we mentioned the term critical titer. So a critical titer of the antibody is the titer above which there's a risk of hemolytic disease of the fetus that requires closer monitoring. It is not diagnostic that babe has anemia, but it is a flag for us that we need to check through a different mechanism. For anti-D, and this is actually where all the studies have been done to identify a critical titer, it's greater than 1 in 16 using tube testing. Again, depending on your local lab, it may be slightly different, anywhere between 8 to 32, but I would say the usual standard is greater than 1 in 16. For all of our non-anti-D antibodies, with the exception of Kel, we extrapolate and say, oh, a critical titer is probably greater than 1 in 16, but I will caution you that we actually have not done those studies in the non-D antibodies. Anti-K, which we won't talk too much about today, but so this is a antibody that can cause both hemolysis and marrow suppression in the fetus. This is one that really needs closer assessment because at lower titers, there's a strong association with requiring intrauterine transfusion. So I agree with the majority that this patient needs to be referred to a high-risk OB center for MCA Doppler assessment. And really, in my mind, there are 3 situations where this needs to happen. So if a critical titer of a clinically significant antibody is reached, anti-K really at any titer is worth connecting with a high-risk OB center, or if there's a previously affected pregnancy with hemolytic disease of the fetus. And what they're doing with an MCA Doppler is they're looking at the rate of blood flow through the mean cerebral artery of the fetus. And when a babe becomes anemic, this rate increases. And so it gets reported as multiples of the mean, or MOM. And really anything greater than 1.5 is concerning for fetal anemia. So our patient gets referred for MCA Dopplers. At 24 weeks gestation, they become abnormal. And fetal blood sampling confirms anemia. Then the fetus requires intrauterine transfusion. And so you can see here, it's very steady hands, and they cannulate often the umbilical vein to sample the fetal blood and to transfuse. So the fetus is transfused, and we do group O, antigen negative, K negative red cells. And we can actually quite easily predict how often babe will need transfusions. So usually a little bit more frequently up front while there's still circulating D positive cells that are getting hemolyzed. And then as the transfused cells start to replace the fetal cells, then the rate of transfusion is actually slows down. And we would induce at 37 weeks gestation. So lastly, when we're looking at neonatal consequences, in babes that were transfused in utero, I'll step back. In all babes, there's always a risk of hemolysis. Remember, maternal antibodies will continue to circulate, especially in kind of early days and weeks, and can cause hemolysis. But in babes that were transfused in utero, their marrow is suppressed. And so these babes need to be followed very closely by pediatrics for anemia, because it takes time for their marrow to start kicking in and for them to make their own red cells. In general, in newborns, so the spectrum of treatments can include phototherapy. IVIG, the role is really unclear and is falling out of favor. Neonatal transfusion, or in more extreme cases, exchange transfusion, where we take out the antigen positive fetal cells and we replace it with antigen negative donor cells. So in summary, remember, we're doing this antibody screen in the late first, early second trimester to detect clinically significant alloantibodies. Once an antibody is identified, we're risk stratifying with paternal testing and, if available, cell-free fetal DNA. We're using serial titration to monitor the titers of this antibody as a risk of fetal anemia, and above a critical titer, we need to monitor with MCA Doppler ultrasound. In the rare cases that require intrauterine transfusion, it's highly effective, and outcomes have actually become quite excellent with intrauterine transfusion, but we do need to monitor the newborn closely for anemia. So with that, I will thank you for your attention, and I think we're doing questions after the next presentation. So I will pass over to my colleague. Thank you.
Thanks so much, Heather. That was a really great talk. I'm sure there are a lot of questions that should be coming through. I'm going to ask Garrick, if you don't mind sharing your slides. We'll then move on to thrombocytopenia in pregnancy. And then, like I say, if you have any questions, please post them in the chat, and we'll do questions for both speakers at the end of the meeting.
Thank you so much, Heather and Jared. So we'll start with a case, just to start off. So the first case is of Miss AC. She's a 38-year-old female. She's para 1, gravida 2. She had no pregnancy or fetal losses, and she was diagnosed with ITP at the age of 11. So it was chronic and refractory, and you'll see her treatment in the later slide. Her secondary workup for ITP was non-contributory. She is otherwise HIV negative, no autoimmune features. And she had comorbid conditions, so she was hypertensive. She also had associated iron deficiency anemia with a multifibroid uterus, which we thought was the etiology of that. You'll see here that she's had multiple therapeutic options previously, or that were used previously. And I think this just shows that the treatment in ITP, that the landscape is quite complex. So it's about using what treatment has been used before, what worked before, minimizing side effects in a pregnant female, conception planning for future pregnancies, as well as the roles of vaccine and vaccination. So you'll see this patient has been on prednisone, was steroid dependent. She received a number of lines of immunosuppressive treatment previously. Just be aware of the agents that are contraindicated in pregnancy. She's had previous rituximab use, vincristine. IVIG has been used successfully in her previous pregnancies in order to make sure that she's has an adequate platelet count for delivery. And she's also had a previous splenectomy. So being aware that you need to make sure that these patients are vaccinated. Just to look at a quick glance of her delivery. So this was in 2022. She had an elective C-section booked for the 18th of March 2022, and you'll see how we used or successfully used intravenous immunoglobulin for 3 days prior to pregnancy in order to elevate that platelet count to a safe level for neuraxial anesthesia as well as for delivery of the fetus. I'm just going to take you through an approach to bleeding and thrombocytopenia. So let's just remind ourselves of the various bleeding manifestations in skin and the mucous membrane. So we're going through this now. So generally petechiae are pinpoint hemorrhages, which you can see over areas of pressure. So generally over areas where there's tight clothing or over the shins, and it's generally 1 to 2 millimeters. You can then have a confluence of a petechiae to form purpura. So these are either wet or they can be dry, for example, in the skin, or wet in the mucous membranes. They're generally non-palpable, so that differentiates it from your other causes of palpable purpura, so the vasculitides, infections or rickettsial infections, as well as cryoglobulinemia, and they're generally non-blanching. You'll see ecchymoses, again, quite significant bruising, and these are potentially abnormal when there are more than 5 bruises that are present. And just to be aware of the various occult sites of bleeding in patients with low platelets, so always be able to assess for the presence or absence of visual loss or visual changes. So you see that you can have a range of features on the retina, so Roth spots, boat-shaped hemorrhages, your flame-shaped hemorrhages, as well as your dots and blot hemorrhages. The World Health Organization uses this standard grading system for the grading of bleeding in patients with ITP or with thrombocytopenia. This is basically just used to standardize the reporting of bleeding severity. And just be aware that bleeding is sometimes on a continuum, and there can be multiple various sites of bleeding in one patient, and the bleeding can evolve and severity may change. So let's just go through some of the T's of thrombocytopenia. So we'll go through some of the alarm features or the features that you should always exclude in a patient with thrombocytopenia, and we'll see how that's relevant to pregnancy. But just being aware that the differential for thrombocytopenia is quite broad, and then that we have to delineate between benign processes in which observation is alone is important or appropriate, and differentiate this from life-threatening conditions in which timely intervention is required. So if we go through the assessment of the T's in thrombocytopenia, you should always assess, is this a true thrombocytopenia? So you'll see in this slide here that there's platelet clumping, and this can be a possible cause for a pseudothrombocytopenia. So this shows you the importance of a peripheral blood morphology analysis. And it's also important to examine the red blood cells. You'll see that the examination of the red blood cells on this slide, that there are a number of red cell fragments in the slide, and there can be various iterations of the red cell fragments. So keratocytes, helmet cells, triangle schistocytes, as well as microspherocytes. And just being aware that in order to make a diagnosis or consider a microangiopathic process is the counting of 1,000 red blood cells. With healthy adults and full-term neonates, if they have more than 1% fragments, this constitutes or is suggestive of underlying mechanical breakdown of the red blood cells. It's also important to consider red cells in terms of the red cell inclusions. So we should always consider malaria in a patient who travels to South Africa. And I think this is important in our setting when a lot of pregnant patients travel to South Africa for obstetric care. So now we've looked at the presence or absence of red cell fragments and pseudothrombocytopenia. We have to assess the timing of the thrombocytopenia. So this timing is in terms of when it occurred in the trimester of pregnancy, as well as previous counts in previous pregnancies. We also have to consider the context of the thrombocytopenia in our patients. So does this patient have systemic features? So is the patient well, unwell? Are they an inpatient, outpatient? Are there features of infection or sepsis? And does the patient have or use any medications currently? We also have to consider the trough or the nadir of counts, so the lowest that the platelet count has been. And this is important in differentiating certain features of thrombotic microangiopathy, for example, secondary to TTP, as opposed to gestational thrombocytopenia. So the T's of thrombocytopenia, we should always consider an inpatient, outpatient setting, in a well patient, and an unwell patient. We should also always consider the overall picture of is the patient HIV positive or negative, and I think we have to consider that the first presentation of anemia or thrombocytopenia can lead to an underlying HIV diagnosis. So if we just look at decreased production, so these are mechanistic approaches to thrombocytopenia, we'll see that are there associated cytopenias, so is there bicytopenia or pancytopenia, and this could implicate bone marrow failure syndromes as a cause for the underlying thrombocytopenia. Is there coexisting liver disease in which the synthetic function of the liver is reduced? Is there increased consumption? So this consumption can be in the microvasculature in terms of thrombotic microangiopathies, consumption or destruction in large vessels, so that, for example, patients with intra-aortic balloon pumps, consumption in surgery, and then also consumption in external circuits, so considering ECMO or bypass machines. We also have to consider immune-mediated mechanisms of platelet destruction, so ITP, drug-induced, so a number of drugs which will take a good drug history, coexisting HIT or heparin-induced thrombocytopenia, so we have to look at the timing of the thrombocytopenia, as well as the trough or the nadir of counts. And is this transfusion related? So has the patient received multiple previous platelet transfusions and now has platelet refractoriness? And then consider miscellaneous causes, so redistribution or dilution. So redistribution, so within spleen, so hypersplenism, or dilution with massive fluid resuscitation, and considering gestational thrombocytopenia as one of them, as a dilutional mechanism as the plasma volume expands in pregnancy. So you'll see that it's broad, but also consider that the initial presentation of someone who is newly diagnosed HIV positive may also lead to underlying thrombocytopenia. So let's just look at gestational thrombocytopenia and immune thrombocytopenia. So you'll see that the relative proportion of the causes of thrombocytopenia with a platelet count less than 150 in pregnancy, that the overwhelming majority is, or 76% of cases, is generally secondary to gestational thrombocytopenia. And being aware that an ITP diagnosis requires a platelet count of less than 100 times 10 to the 9. This basically just shows you that thrombocytopenia can occur at any trimester in pregnancy and can also occur postpartum, and we'll get to some of the causes of that. And most of the occurrences of thrombocytopenia occur in the third trimester. And narrowing the diagnosis depends on, again, the timing by trimester, as well as when it occurred first time in pregnancy. Also considering the nadir of counts, or the lowest or the trough counts of the platelets. So this is just the features of gestational thrombocytopenia as a diagnosis. So the mechanism of gestational thrombocytopenia is considered unclear with no clear explanation, but some postulates are hemodilution, consumption or sequestration in the placental circulation, inefficient thrombopoietin production, and most importantly is that the counts recover postpartum to a normal level. So I've tried to look through a pattern, so it's generally retrospective with resolution after delivery. There's a late onset. There's really a significant bleed in both mom and the fetus. There's recovery rapidly and spontaneously postpartum, and there is or can be recurrence in future pregnancies. And this is a case in which observation alone is part of the treatment. If you consider immune thrombocytopenia, it's diagnosed in less than 0.1% of all pregnancies and occurs at any time in pregnancy, but most commonly in the first and early second trimester. And little is known about the differences in ITP secondary to pregnancy compared with that in non-pregnant patients. But there's a speculation that there's a change or in the normal shift from a T helper 2 cytokine profile to that of a T helper 1 cytokine profile. And this may initiate abnormal and autoimmune processes. So if we consider immune thrombocytopenia and the platelet targets for therapy. So generally, if the pregnancy is less than 8 months, the treatment should only be initiated when the platelet count falls below 20 times 10 to the 9, or if there's associated bleeding. And the American College of Obstetrics and Gynecology uses a platelet count of less than 30. If it's from 8 months to delivery, all of the preparation is in approaching delivery and making sure that there's a safe delivery without any bleeding. So just being aware that you may have to increase the intensity of therapy approaching delivery. Being aware of the platelet targets, so epidural anesthesia, generally platelet count required is greater than 70 times 10 to the 9. Abdominal surgery with no neuraxial anesthesia is a count that's required is about 50. And then vaginal delivery, an ideal platelet count is more than 50, with the increased risk of postpartum hemorrhage with counts less than 50. But with all of this, you have to consider other factors. So is there concomitant anticoagulant use? Is there or are there competing coagulopathies? Is there renal or liver dysfunction? And also to anticipate the blood loss or bleeding during delivery. These are the platelet thresholds from the JAMA article from 2025 from May on platelet transfusions and thresholds. So in a consumptive thrombocytopenia, for example, DIC with no major bleeding, generally would only transfuse platelets if there was bleeding and platelet count was less than 10. For CVC placements in compressible anatomic sites, platelet counts we would only transfuse if they were less than 10. And then major non-neuraxial surgery, generally transfuse platelets if the counts were less than 50. And just being aware of the different treatments of immune thrombocytopenia in pregnancy. There's first-line therapies with corticosteroids and intravenous immunoglobulin, and then various second-line treatments. But the treatment of the pregnant patient with ITP differs from that of non-pregnant patients in the exclusion of medications that may be regarded as toxic to the fetus or that are insufficiently studied for their safety profile. If we look at prednisone, that it's generally the corticosteroid of choice. It occurs in small amounts in cord blood as opposed to dexamethasone, which occurs causes high fetal concentrations. Being aware that prednisone may aggravate gestational diabetes, hypertension, and may result in various neuropsychiatric features in the pregnant patient. And then some considerations have been for a brief trial of prednisone for 40 milligrams daily for at least 5 days at about 30 to 32 weeks to assess response. So this is in a patient, for example, who's managed to have a platelet count above 20 to 30 for most of pregnancy. And they say that you can then generally trial prednisone from 40 milligrams daily for 5 days in week 30 to 32 and assess if the patient will respond to this prednisone trial. And this may guide management for labor and delivery. If the response is poor, it may indicate patients in whom you may need to use IVIG prior to delivery. So intravenous immunoglobulin generally used at doses of 400 milligrams per kg to up to 2 grams per kg, and this is given in divided doses over 1 to 5 days. And then most patients don't require significant treatment during the first 8 months of pregnancy, and then you can consider intermittent pulses of IVIG or steroids if needed during the pregnancy. So treatments that are contraindicated in pregnancy or in conception planning would be danazole, your MMF, cyclophosphamide, fostamatinib, as well as vincristine. A lot of our agents that we use as second-line treatment, they studied in other diseases in pregnancy, so diseases other than ITP, and have shown safety profiles there. So azathioprine, for example, in renal transplantation, cyclosporin, inflammatory bowel disease, dapsone with malaria in pregnancy, and then rituximab for its use in lymphoma in patients who are pregnant. With rituximab, its use has increased substantially for ITP, and it appears to be safe in pregnancy, provided it's not given, within the later stages of pregnancy, as it may cause inappropriate responses to vaccinations in the fetus, neonatal hypogammaglobulinemia if used late in pregnancy. And just being aware that there's a delayed onset of action for these second-line therapies with a response rate of about 40 to 50%. And splenectomy may remain an option in patients who remain refractory to treatment. However, it should be performed early in the second trimester, and there's also very few centers which would actually contemplate intrapartum splenectomy, and most of the data is from single case reports. If we look at the use of thrombopoietin receptor agonists, so all of them cross the placenta. There's only been one agent with recombinant human TPO, which is available in China, which does not cross the placenta. And most of the articles or BMJ particularly from 2023 favors the use of romuplastin, generally in the last trimester, in patients who don't respond to corticosteroids or intravenous immunoglobulin. And they've shown that there was data in more than 70 women who conceived on it and did not have an abnormal child. However, they did not specify the long-term follow-up in those children. So just being aware of the ITP treatment landscape, generally maintaining platelet count more than 20 to 30 is sufficient, and then planning in the later stages or later trimesters for delivery. So just being aware of our delivery targets for surgery, as well as epidural anesthesia. Let's just move on to pregnancy-associated thrombotic microangiopathies. So the classification of your thrombotic microangiopathies are either primary or secondary. So primary would be your congenital TTP, so Upshaw-Schulman syndrome, as well as your atypical hemolytic uremic syndrome. and then those secondary conditions. So your pregnancy-related hypertensive conditions, acute fatty liver of pregnancy, antiphospholipid syndrome, and then HUS secondary to sugar toxin-associated HUS, and then DIC. So we look at the overview of pregnancy-associated thrombotic microangiopathies that generally reflects a syndrome of endothelial injury. So that's the site of where this all takes place within the microvasculature, with thrombocytopenia, mechanical hemolysis, as well as organ insults, so to the kidney, the brain, as well as the heart. When should you suspect thrombotic microangiopathies? So generally thrombocytopenia, platelet counts less than 100, acute kidney injury, which is less common in TTP and more common in hemolytic uremic syndrome, hemoglobin less than 10, an LDH, which is more than 1.5 times the upper limit of normal, a negative direct antiglobulin or Coombs testing, as well as features of mechanical hemolysis on the blood smear. So those would be your schistocytes. If you consider the fields of pentads and triads, so again, this was the pentad for classic TTP previously described, but it's more likely to be a triad now of thrombocytopenia, microangiopathic hemolysis, as well as an organ insult. But beyond pentads and triads, there's more of a vicious cycle with the formation of thrombi within the microvasculature, and then consumption of platelets and mechanical destruction of your red blood cells within those microthrombi. If we follow an algorithm for TMA in pregnancy, let's just go through a few of these features. So first start with the pregnancy-associated hypertensive conditions. So just being aware of the different cutoffs, so less than 20 weeks estimated or gestational age, that would be the domain for chronic hypertension, and your pregnancy-associated hypertensive disorders beyond 20 weeks. Just being aware of the blood pressure targets, as well as always to check the urine for proteinuria, as well as to assess the platelet counts. And we'll go through a few of these conditions now. Just being aware that in a patient with new onset hypertension without proteinuria, you can still make the diagnosis of preeclampsia just based on the features of severity that may be present. So you'll see that one of them is thrombocytopenia with a platelet count of less than 100. So this is the pathogenesis of preeclampsia, and if we assume that the pathogenesis of HELLP syndrome is similar, if we assume that HELLP is a severe form of preeclampsia, you'll see that there's failure of the trophoblast to transform to proliferative or to invade the spiral arteries. So you'll see that there's shallow placentation and there's defective thromboblast invasion of the spiral arteries and deficient spiral artery remodeling. This results in placental hypoperfusion, and beyond this, it results in placental ischemia with oxidative stress. This also results in increase in anti-angiogenic factors, so your soluble FMS-like tyrosine kinase 1, and also a decrease in your pro-angiogenic factors, such as your placental growth factor. And there's also certain ratios that you can use with these different kinases and growth factors in order to estimate those patients and which the history, the findings are suggestive of preeclampsia, eclampsia, or HELLP syndrome. The resultant placental ischemia results in local and systemic endothelial dysfunction, and this then is the inciting event for thrombocytopenia. If we look at the different diagnostic criteria for HELLP syndrome, there's a Tennessee classification, Mississippi classification, as well as the ACOG classification. And you'll see the various platelet counts with the Tennessee classification, counts of your platelets less than 100, platelet class or classing according to the Mississippi classification with your platelet counts less than 50, 50 to 100, or from 100 to 150, and then with the ACOG, a platelet count of less than 100. So with HELLP syndrome, the approach to treatment is fetal delivery. In addition to that is hypertensive control with or without the use of aspirin, magnesium, and then betamethasone for fetal lung maturity. If we move on to other thrombotic microangiopathies, we'll move on to TTP. So with TTP in pregnancy, we know that with TTP that there's a severe deficiency of your cleaving enzyme ADAMTS13, and this results in the formation of ultra-large von Willebrand's multimers. These multimers then form or basically exist in the endothelium, and they basically aggregate and cause platelets to adhere and to aggregate, forming microthrombi within the vasculature. This results in the mechanical hemolysis or breakdown of your red cells as it passes through these microthrombi. So TTP generally occurs at a rate of 2 per 100,000 in pregnancies, and it accounts generally for 12 to 25% of adult onset TTP cases. But just being aware that the measurement of your ADAMTS13 levels, they may also decrease in preeclampsia, eclampsia, HELLP syndrome, as well as pregnancy-associated HUS. but not less than 20%. So this is a useful test or serum marker that will help delineate between TTP as well as your other thrombotic microangiopathies. Remember that TTP can associate with other autoimmune disorders, so it can manifest before, during, or after pregnancy. Just being aware of the two different types of TTP, it's either congenital. So this is a recessive mutation which occurs in ADAMTS13 gene. So patients are either homozygous or compound heterozygotes, or there's idiopathic or acquired TTP, which we often see in our setting. And this is acquired autoantibodies, which will inhibit the proteolytic activity of ADAMTS13. So in majority of cases, about 75% of cases, we have anti-ADAMTS13 IgG antibodies. You'll see that in most patients that there's an equilibrium between von Willebrand's factor levels as well as ADAMTS13. This is, however, changed in pregnancy. So we have an increase in von Willebrand's factor in pregnancy with an increase in the first trimester, and this has remained supernormal even 6 weeks postpartum. And this is in preparation for delivery. And as I mentioned, this maximum increases in the last trimester. We have a resultant decrease in the ADAMTS13 metalloproteinase, and this decreases from the second trimester to the end of the early postnatal period. And there's quite a significant control of estrogen over the protease, which will also play a role in the overall TTP and the picture in pregnancy. So if we look at TTP in the diagnostics, is that it's generally based on ADAMTS13 activity. So this is less than 10% or between 15 to 20%. And then based on whether or not there's antibodies that are positive or negative. So generally with congenital TTP, they would be antibody negative, but would still have a low ADAMTS13 activity. And in patients with acquired or idiopathic TTP, they would have antibodies that were positive. Being aware of alternative diagnoses, so you can also have decreased ADAMTS13 levels between 20 to 40% in patients with preeclampsia, eclampsia, HELLP syndrome, or pregnancy-associated HUS, but generally would still remain detectable. So there are various scores that have been used in non-pregnant patients which predict the likelihood of the severity of ADAMTS13 deficiency, and these scores are the plasmic score as well as the French score. And they've said that you can use these in pregnancy, provided, or if you don't have access to ADAMTS13. However, they are not validated in pregnancy, though. But it may give you an index of suspicion for the likelihood of ADAMTS13 deficiency in TTP. So this is the plasmic score, which basically based on platelet count, serum creatinine levels. You'll see that in the presence of renal failure in TTP as compared to HUS is not that great. It's more common in HUS. And you'll see this exclusion of an MCV, your INR, of features of other coagulopathies. And this is then used as a predicting tool for the likelihood of severe ADAMTS13 deficiency with a level less than 10%. But as I mentioned, it's not validated in pregnancy, but may be used in certain circumstances in which you don't have access to ADAMTS13 levels. So treatment is dependent on a timely diagnosis. You should always consider this in a pregnant patient who has biochemical features of an acute thrombotic microangiopathy, especially if there's a platelet count which is less than 30. So 30 is kind of the nadir of counts that we look at. They also have an absence of mild, or they have the presence of maybe mild renal dysfunction, but they generally only have mild renal dysfunctions, not significant. And also in a patient with, who has neurological impairment, we should also consider the presence of a thrombotic microangiopathy in the form of TTP. We should also consider the different treatment landscapes in idiopathic TTP, so the general standard of treatment there is plasma exchange as well as corticosteroids. And in congenital TTP, we have to administer fresh frozen plasma. And the general role of fresh frozen plasma generally has to be administered throughout pregnancy based on the ADAMTS13 levels. For plasma exchange in TTP in pregnancy, it's generally 1 to 1.5 times the plasma volume. So it's about 40 to 60 mils of fresh frozen plasma each day. And we can generally consider steroids as well, so pulse doses of methylpred or solumedrol, or oral therapy of prednisone at 1 milligram per kg. And this is generally tapered over 2 to 3 months. And prophylactic plasma infusions in congenital TTP generally takes place or initiated at 10 weeks and is then basically dosed according to the level of ADAMTS13. Aspirin is not routinely prescribed unless there's a specific gynecological indication in patients with TTP. So the question always arises about platelet transfusions in TTP, and from the literature, from various articles on TTP and pregnancy from blood, is that platelet transfusions should be avoided in a patient's TTP due to the concerns that there may be worsening thrombosis and worsening neurological symptoms. And then if patients do require platelet transfusions, and if they are urgently required, it should be administered along with plasma exchange. The use of caplacizumab. So caplacizumab is a monoclonal antibody, or a mAb, which binds specifically to the A1 domain in von Willebrand's factor and prevents it from binding to platelets, forming the microthrombi. And this then blocks the formation of platelet-rich microthrombi, which are central to the pathology of acquired TTP. And you'll see that in a lot of patients, there's only been limited to case reports, so all from the British Journal of Haematology. And you'll see that in most cases, or this case here, in which the patient had a TOP at 21 weeks, that there was a supervening diagnosis of PET in this patient, so preeclampsia. But in these other two cases, there was delivery of the fetus, and there were no adverse outcomes in the mother and the fetus immediately postpartum. However, it probably require more data on this or the use of caplacizumab in pregnancy. Just being aware of the different features of TTP in congenital or acquired in pregnancy. Just being aware that, with congenital TTP, that considering the levels of ADAMTS13 decrease in pregnancy, you can then unmask congenital TTP within pregnancy. We have a nadir of counts or nadir of your ADAMTS13 levels to around 20 to 40%, which takes place in pregnancy. And you can imagine that in someone with congenital TTP, that the further decreases in the level of ADAMTS13 would precipitate the features of a thrombotic microangiopathy. So being aware in congenital TTP, there's no inhibitors, as opposed to acquired TTP in pregnancy, in which there are the presence of inhibitors with decreased activity level less than 10%. Just being aware of counseling patients about the risk of relapse, particularly with congenital TTP, that there is a risk of gravidic relapse, which is almost 100%, and the risk of gravidic relapse could be possible in acquired TTP as well. If we look at other coagulopathies with thrombotic microangiopathies in pregnancy, there's acute fatty liver of pregnancy, which is a rare disease, and approximate incidence of 1 in 7,000 to 1 in 20,000 pregnancies. And this is a result in defects in mitochondrial beta oxidation of fatty acids due to fetal maternal mutations in LCHAD, so long chain 3-hydroxyacyl CoA dehydrogenase, or other enzymes in the fatty acid oxidation pathway. And this results in the accumulation of toxic fatty acid metabolites in the maternal liver. And this causes microvesicular steatosis, hepatotoxicity, impaired liver function, and features of a coagulopathy. So the systemic complications are generally coagulopathy, hypoglycemia, and renal impairment. And the thrombocytopenia in acute fatty liver pregnancy can be multifactorial, because you can have coexisting HELP syndrome, which occurs in 20% of patients, and coexisting preeclampsia with severe features in 20 to 40% of patients. And just being, again, aware of the timing of acute fatty liver in pregnancy, that are generally between the 30th and 38th week of gestation, but can be made as early as 18 weeks and as late as 4 days after delivery. This is just the diagnostic criteria for acute fatty liver pregnancy, and just being aware that thrombocytopenia doesn't form a major part of the diagnostics. It's mostly as a result or based on symptoms, as well as features of liver dysfunction. So acute fatty liver pregnancy, primary treatment is fetal delivery. It's unlikely to fully resolve the liver injury, and you may require a liver transplantation in severe cases, and also to assess for the fatty acid oxidation enzyme defects. So moving on to those associated with autoimmune diseases and thrombotic microangiopathies. So antiphospholipid syndrome, we know that the diagnostic criteria changed recently. So the entry criteria are more than one documented clinical criterion. So this is based according to these 6 domains. And you'll see that one of them is the hematological domain, with a thrombocytopenia with the lowest or nadir of counts from 20 to 130, and a positive APL test within 3 years of the clinical criterion. So those positive tests are the lupus anticoagulant, your ACLA or anticardiolipin antibodies, or your anti-beta-2 glycoprotein antibodies. And then classifying antiphospholipid syndrome for research purposes is if there are more than 3 points from clinical domains, so those 6 clinical domains, and then 3 points from laboratory domains. Being aware of the treatment of pregnant and postpartum patients with antiphospholipid syndrome is based on the thrombotic APS with or without obstetric APS. So that basically is anticoagulation with low molecular weight heparin and low dose aspirin. And then this basically reiterates the same features as therapeutic anticoagulation in these patients. So low molecular weight heparin as well as your aspirin. There are other thrombotic microangiopathies in pregnancy that are rarer or that are rarely described from this flow diagram. So they are the sugar-like toxin producing E. coli, your cobalamin C deficiency, which has also been implicated in rarer forms of thrombotic microangiopathies, TMAs that are not related to pregnancy, that are induced by drugs, infections, or malignancy, and then severe B12 deficiency is a mimicker of thrombotic microangiopathies. So being aware that severe B12 deficiency may cause a pancytopenia, thrombocytopenia, and in the presence of intramedullary within the bone marrow hemolysis produces red cell fragments, and these then may be visible on the peripheral blood smear and may produce a picture of a thrombotic microangiopathy. So just being aware of another diagnosis is atypical hemolytic uremic syndrome, that it's a diagnosis of exclusion, that the results of complement workups, you'll see here looking at the levels of complement C3, C4, factor H, factor I, factor B. These are all, they're not required for an atypical HUS diagnosis, but may corroborate the diagnosis. So pregnancy-associated HUS is rare. It does belong to the spectrum of complement-mediated HUS, and it's the only form of a thrombotic microangiopathy to occur most frequently in the postpartum period, so even up to 3 months after delivery. So you'll see this is, the timing is important in delivery or in pregnancy when the thrombocytopenia occurred. As I mentioned earlier, that the presence or the predominance of severe kidney injury is more common in atypical HUS as opposed to TTP, and then being aware of the risk of recurrence in subsequent pregnancies. This slide is just to show you that there's abnormalities in the alternative complement pathway, that there are gain-of-function mutations of complement activators, and then loss-of-function mutations of your complement regulators. The downstream effects of this alternative pathway activation is, or excessive activation of the pathway, is platelet activation in the microvasculature on the endothelium, and in the formation of microthrombi and subsequent hemolysis or breakdown of your red blood cells as they pass through this microthrombi. Again, the treatment for complement-mediated thrombotic microangiopathies is based on the use of complement inhibitors, so C5 inhibitors. This is eculizumab or evolizumab, and they have shown good data in paroxysmal nocturnal hemoglobinuria, as well as pregnancy and safety data from PNH. There has been use of plasma exchange or plasma products in complement-mediated thrombotic microangiopathies. However, efficacy is limited with the use of this. So being aware of certain events such as secondary TMAs or thrombotic microangiopathies, that DIC is a common cause, that in pregnant patients the underlying causes or initiating or inciting events may be amniotic fluid embolism, abruptio placenta, HELLP syndrome, eclampsia, and septic miscarriages as well. That pregnancy-associated DIC accounts for approximately 1 to 5% of all cases of a DIC, and this is in resource-abundant countries, and I think that this is probably high in resource-limited countries and settings. Just being aware that we often see patients with DIC more with impaired coagulation and with a bleeding profile and the consumption of platelets within that disseminated intravascular coagulation. We can or have used the ISTH scoring system for an overt DIC in pregnancy as well as outside of the pregnancy setting. However, it has not been validated, and there are a few other studies which have used certain iterations or modifications of the ISTH score. So there are pregnancy-modified ISTH DIC scores, but it mostly identifies those patients who require blood and blood products for transfusion. There are also other diagnostic criteria or diagnostic scoring systems which can be used in overt DIC, such as the non-overt DIC scoring system and the Japan Society of Obstetrics and Gynecology scoring system. but they have their limitations that it requires more workup. So you require more workup of laboratory markers, antithrombin 3, protein C, thrombin, antithrombin 3 complexes. And the utility of this is that it identifies patients who may require blood and blood product support, which I think that you can kind of garner from using simple mechanisms or laboratory measures like INR, PTT, as well as your full blood count. The management of DIC in pregnancy is largely supportive. So it's important to rely on an MDT team so for optimization for surgery or for any intervention that is required, vascular access and fluid support, as well as blood product support and being aware of your transfusion triggers, optimizing your physiological reserve, so supplemental oxygen may be used, keeping the patient warm to prevent further coagulopathies, always treating the trigger and treating to target, and then monitoring the mother and the fetus. So let's move to a take-home message. So this is basically the overall landscape of thrombocytopenia in pregnancy, and we'll go through or remind ourselves of some of the T's of thrombocytopenia. So is it a true thrombocytopenia? So is this true? And always ask for a slide review. If you see thrombocytopenia, you should always ask for a slide review to, number one, confirm that it's a true thrombocytopenia, as well as to assess for the background red blood cells if there are features of mechanical breakdown or mechanical breakdown of your red blood cells. Are there features of the thrombotic microangiopathy? So your red flag should always be to look for fragmented red cells. And the timing. So always being aware is which trimester did it occur in, and also remember that it can occur postpartum in atypical HUS or TTP. This is basically just to remind ourselves of the timing of thrombocytopenia in pregnancy. So being aware of the hypertensive diseases in pregnancy, so with chronic hypertension less than 20 weeks of gestational age, and then your gestational hypertensive disorders from 20 weeks onwards. Being aware of the changes in coagulation, or normal coagulation in pregnancy, and being aware that hypercoagulability is more pronounced in the late third trimester. So we have increase in von Willebrand's factor, and we have decreased ADAMTS13. And this results, or the imbalance results, or can result in your thrombotic microangiopathies. Being aware that ITP and gestational thrombocytopenia, so ITP generally occurs in the first and the second trimester, and then being aware of your thrombotic microangiopathies. So being aware of acute antiphospholipid syndrome, being aware of your embryonic losses in less than 10 weeks, and your fetal losses of morphologically normal fetus between 16 to 33 weeks. Acute fatty liver of pregnancy, being aware that it can occur from 18 weeks to even 4 days postpartum. And then being aware that pregnancy-associated HUS can occur, or is the only form of a TMA that may occur most frequently in the postpartum period, and even up to 3 months postpartum. I think that the take-home message is that if there's an absence of stabilization or improvement in your counts within 48 hours following delivery, this usually rules out pregnancy-associated or disorders like preeclampsia and HELLP syndrome. That preeclampsia and HELLP should actually resolve within 48 hours with your counts following fetal delivery. And being aware that TTP or that complement-mediated HUS does not improve or could even worsen after delivery. Looking at your pregnancy-associated thrombotic microangiopathies, you should also look at the relative frequency of them in your population and how often they would occur. So being aware to exclude preeclampsia as well as HELLP syndromes that occur more commonly than TTP, as well as complement-mediated HUS. Always consider the context of the patient. We should always treat the patient, never the counts. So being aware that there are other features of the context. So that's basically looking at the blood pressure, looking at if there is an isolated thrombocytopenia or if other blood cell counts are affected, other features of a coagulopathy, the overall wellness of the patient, so do they have neurological features, and being aware if there is associated proteinuria or acute kidney injury. Also being aware that we should also consider the confounding features of HIV as well as other viral infections like hepatitis. We should consider the trough or the nadir of counts, so that may be an indication of severity of the underlying condition, say for example TTP with the platelet count less than 30, and this also helps us plan for labor and delivery. Being aware of the trough or the nadir of counts with your thrombocytopenia in pregnancy, so remember that 7 to 11% of pregnancies have a platelet count which is less than 150. Diagnosing ITP with pregnancy is less than 100. Being aware that with gestational thrombocytopenia that the counts of your platelets are generally rarely less than 70. And then if you have platelet counts of less than 30, consider TTP. Being aware of the treatment landscape depends on the severity of those counts, as well as assessing the response of delivery to your counts. Being aware of your targets for your platelet counts, so for delivery and your axial anesthesia, and then always making sure that you employ a team approach. So obstetrician, gynecologist, neonatologist, hematologist, and your maternal internal medicine specialists. Thank you so much.
Thanks so much, Garrick. Really good overview there of thrombocytopenia. I'm just having a look at the time. It's 5:10, and just seeing if there are any pertinent questions. There are quite a few comments in the chat that everyone could go have a look at. I think one important one there that Prof. Lowe has said, I suspect that TTP rate in our environment is likely higher, especially in HIV positive patients, which Dr. Hull has reiterated there, shown in a study in the SAMJ from many years ago. Just one thing I think I want to ask you, Garrick, just in terms of the slide and sort of a manual platelet count. We often have this concept of, I don't know if it's taught in registrar time or where it's taught, about sending off platelets in a blue top tube. How valid is that? How useful is that actually?
I think in cases, if you have examined the peripheral blood smear and you've seen that there is platelet clumping, then you could consider sending off in a citrate top tube. But if there's no platelet clumping and does look like a true thrombocytopenia from the peripheral blood smear, I think that wouldn't be that useful to send off a citrate top tube. But certainly, if there is platelet clumping, it would be useful to do that.
Okay. We've also found in our center that we've had a few issues with sort of the automated analyzer picking up large platelets as red cells. And then when you do a manual count, it's, the platelets aren't as low as expected. Have you seen that at all at Barra?
I do think that would be a consideration. So that would be some of your confounding features. So that's us always go back to the basics of looking at your full blood count and also looking and assessing the platelet or the patient's overall clinical features. So do they match their platelet count? So if they've got a platelet count of 1 and they're not bleeding, you should always wonder, is this my patient's result? Is this a true result? And then always going back to the patient is always centered to that, and then looking at your peripheral blood smear. So I think that's important.
Okay. I think I'm going to ask a question for Heather now, if Heather's still on. Yeah, Heather, you there. In terms of, so I think probably looking at resources might be a little bit different between South Africa and Canada, and then also within South Africa between the public and the private sector. For rhesus disease, do you routinely screen the dad if mom is rhesus negative?
Yeah, so no, again, I'll call it kind of my bias of our system, but so if mom is Rh negative and has access to Rh immune globulin, then we would just go ahead and give it kind of regardless, unless mom has an objection to Rh, like to blood products essentially. And then in that case, we would look at dad. If dad were Rh negative and mom were certain that this was the paternity was assured, then we would forego Rh immune globulin. But yeah, we wouldn't routinely screen, and we would just kind of prophylactically give rig, again, kind of thinking about non-paternity and access to paternal testing.
Okay. There was a question as well, are there any centers in South Africa able to do intrauterine transfusion? There, I can comment on that just on the side message to colleagues. So it can be done in state. I know at Charlotte Macheke we do it, and then quite a few of the maternal fetal medicine specialists in private practice do it as well. I'm not sure about the rest of the country, but I imagine it's done. How often are they done, or how easy is it to access an intrauterine transfusion in your setting? I see Dr. Beloy, I see your hand is up. I'll give you a chance in just a second.
Yeah, so the approach that we've taken in Canada is really having a few centers of excellence, and we know that the more you do these procedures, the lower your complication rates. And so our complication rate, of adverse outcomes is around 1% now with intrauterine transfusion. And part of that has been really bringing people to the experts that do this frequently. And so we actually don't have a lot of sites across Canada, but we have a few dedicated sites. And sorry, I'm just thinking one thing I will comment just about your comment about testing dad. So this is newly coming to Canada. I don't know the South Africa landscape for this, but going forward in the next year or so, we're going to be routinely screening all RHD negative moms for cell-free fetal DNA. So not even bothering with dad, but really to identify those that do need Rh immune globulin and those that do not. So that will be a standard of care practice change for us in the coming year or so. But again, I don't know if that is available in South Africa.
So I think, I mean, cell-free DNA testing, and cell-free DNA testing is not readily available in the public sector. In the private sector, it can be done. A lot of the funders don't end up paying for it unless there's an indication, though. Dr. Beloy, you have your hand up. I'm going to ask you to unmute.
Thank you so much for the presentations. I was just caught by that statement that Heather made, that if the mother sort of swears or vehemently attests that this is the dad, then you don't go any further. I know this is current practice. Can you just elaborate? I mean, is that really valid? Is there no other way? Would you not just go and screen dad anyway?
Sorry, sorry, this was only if mom is like declining Rh immune globulin, and we're looking at other ways. So we would test the fetus. But yeah, I will clarify. There are really rare situations. It's usually not around D. It's for situations where it's around issuing of Rh immune globulin, where you'll have individuals that decline Rh immune globulin based on certainty of paternity and that dad is D negative. That would not be our standard. That is not our kind of clinical recommendation, but that does happen.
Great. I think just there was one more question that did come up. Prof. Verberg, you said you had a pertinent question for Garrick regarding peripartum fetal management of ITP. I'm not sure if you still have the question or.
That's great. I couldn't unmute myself and I couldn't put my camera on for some reason. I don't know why. Let's try again. Anyway,
let me give you a
it's fine.
chance.
Let me just talk.
Perfect.
I just thought it's brilliant talks, both Heather and Garrick, and we can't let Garrick get away so easily without one more difficult talk, after a difficult question. It's a scenario with ITP in pregnancy that I find completely fascinating. And I'm sure the obstetricians will agree with me. It's the baby in the ITP setting, and it's what you do peripartum. And I just think it's important to kind of highlight that for everybody, because I had the pleasure or the dubious pleasure of seeing two mums. The one had ITP and the other one had a history of ITP. Not even ITP, her platelets were 300. But I elicited a history of ITP from her. And with both of them, I told the obstetricians about it. And both of these, we obviously have many people with ITP in pregnancy. And there's no problem with the baby. But in these two cases, the baby had what do we call it, Heather? What is it called? Well, ITP of neonatal ITP. And the point is not that it's so bad for the baby. It is actually that you should have precautions during the delivery. And also, and that's what I found out. That was a great shock to me. Garrick, you rhymed the T with thrombocytopenia. And I can tell you, ITP with a baby with ITP, I can rhyme it with irate. The mums are completely and utterly devastated by the low platelets in their babies. So I don't know if Heather wants to comment or if you want to comment, Garrick. It's quite it's a innocuous enough thing because it can, it passes. But the mothers are even though they were very well counseled, they are completely and utterly shocked. So don't know if there's comment from both Heather and Garrick. Or Jared.
I try and avoid babies at all costs, except for my own two children who I barely keep alive. But I mean, I think definitely the concept of the delivery stuff is really important from the obstetrician side. And I've had, two patients who've now seen me in a subsequent pregnancy where, baby's been delivered by vacuum and then they get this huge bruise or a hematoma because the baby developed neonatal thrombocytopenia. I'm not sure, Heather or Garrick, if either of you are happy to comment about children.
I can say we know about 15% of babes born to mom with ITP are going to have thrombocytopenia from, again, antibodies crossing the placenta and targeting fetal platelets. And so my recommendation to the obstetrical team is that we don't use instrumentation. So we avoid any forceps, we avoid vacuum, and if there's any difficult delivery, then we go to C-section rather than using instrumentation if they can, because yeah, exactly those situations. I think we've all heard through the grapevine of a handful of cases where you get these intracranial bleeds in these babies, and it's absolutely devastating. But thankfully, this does recover quite quickly because similar to hemolytic disease of the newborn, the maternal antibodies will slowly fade away, and fetal platelets will gradually improve.
But yeah, I don't have much more to add to that. The only thing that really came across from the British Medical Journal was where they had, advocated for, fetal sewn of the head post delivery. They'd also, considered in severe neonatal thrombocytopenia that they had advocated for, the cessation of breastfeeding in cases with severe neonatal thrombocytopenia. But for the most cases, they had advocated that the mother can still continue to breastfeed. But in terms of management of the fetus, I'm not entirely sure.
Prof. Berg, I don't know if there's anything else you want to add.
As I said, Garrick, it's simply that I had the dubious pleasure to be presiding over these cases, and it was quite shocking. I've never had a bleed, I mean, a baby that bled or something. But as I said, the shocking thing was, well, the one thing is that one forgets that the obstetrician should be notified if a lady has an history. It was because I had one irate mother with the first one that I was very, very sensitized with the second. I can't even remember why I saw that lady, but because she had a history of ITP, she didn't have it. But for some reason, I probably saw in the clinic and I realized she's pregnant, and it clicked. So I just think it was such a yeah, like a story, it was quite stressful and strange, everything that happened. So it's not only the ITP of the mum, it's also the thrombocytopenia, the transient thrombocytopenia of the baby that can be very, as I said, shocking to the parents. They're absolutely devastated. And I see Dr. Jennifer Coran-Hull has also mentioned about the cord blood of the baby to check, but Heather can probably give comments on that. That's better than me. But I said it was the incredible shock and trauma of the mother that left an indelible impression on me. Even though the baby was fine, it was this, and even though I told her it can happen, it was this incredible devastation of the mother. That was quite, and I saw again what a high risk situation pregnancy is. So it was just a very, I hope everybody will remember to do those things, because it can go wrong. And then if one hasn't done precautions, then it can, it can reflect on you as doctor if the baby wasn't thought of.
I think it's a really good point, Prof. And I've sometimes wander into neonatal ICU and I'm quite shocked at the size of the babies. And, then the pediatricians kind of look at you like, why is there an adult physician in my ICU? So it's, we all have a part to play. And I think on the one hand, we can't leave everything to the obstetricians to manage. we all have to be in it together, and as a multidisciplinary team, everyone has their role to play. So I think on that note, there aren't any more pressing questions in the chat. It's 5:25. I think if you're in Cape Town, you want to beat the rain and get home. If you're in Joburg, you just want to beat the cold. And Heather, I'm sure it's nearly lunchtime for you. So I'm going to close off the session. Thank you everyone for joining. If you have any more questions or comments, obviously feel free to email the Blood SA email address. Please remember that conference that's coming up in September. And then these deep dive webinars will continue next week, Monday, with another talk. So thank you everyone for joining. Thank you, Heather and Garrick.
Thanks, Jared. Thank you. Thank you, Heather.
Thank you, everyone.